Hello, my name is Victoria Obanaya. Today I will be presenting my evidence-based nursing leadership project titled A CNA-led Fall Risk Communication Program in Post-Acute and Long-Term Care. So I currently work in a long-term care center, so this project is prevalent to me because as we've been admitting new patients with higher acuity, we've been seeing more falls. So I wanted to find different ways to be able to address that. So this project focuses on fall prevention through structured communication, education, and leadership-driven change in post-acute and long-term care settings. Falls are one of the most common and preventable adverse events in post-acute and long-term care residence settings. Older adults are especially vulnerable due to changes in mobility, cognition, medication use, and functional status. Certified nursing assistants or licensed nursing assistants all spend the most time with these residents, and they are often the first to observe these subtle changes that could increase fall risk. Despite this, fall prevention efforts frequently rely on nurse-driven assessments and underutilized CNA observations. So I know that in my work, the nurse does 2 med passes and then they will check on the resident from time to time. But overall, it's going to be the CNAs that are primarily answering those call lights and being with the residents. So it just makes more sense that since the CNAs see these residents more, that they should be included in these fall prevention programs. This project proposes a CNA fall risk communication and education program to improve early identification, communication, and fall prevention. So, falls contribute to serious consequences such as injury, hospitalization, loss of independence, and decreased quality of life for residents. So this is going to be bad for the facility as patient safety should be of utmost priority. So if there's an increased risk of falls and documentation, the insurance could retaliate and maybe not send as many people over to that facility. And then also we're striving to be a 5-star rated facility, so an increased amount of falls or episodes of negligence would also hurt our scores. And then the quality of life for those residents, because they are older and they are more at risk for injuries and long-term injuries. We want to make sure that they're not falling because we want them to improve while they're under our care, not worsen. Falls also increase healthcare costs and regulatory penalties for these organizations, as I had just said. Many existing fall prevention programs lack standardized CNA-focused communication processes. Communication gaps between CNAs and nurses can delay recognition of early fall risk cues. And then also those hierarchical structures may discourage CNA reporting or limit formal inclusion in care planning. Sometimes nurses think that CNAs are just there to clean up that patient, but they don't see how much value a CNA could bring and improve their workflow and make sure that their patients are okay. So if they have that, with that hierarchical structure and CNAs feeling like they're unable to talk to the nurses, or if the nurses have a bad attitude or perception on the role of nurses, that could affect the falls and reporting. So for my evidence-based rationale, research demonstrates that nurse-led fall prevention programs reduce fall rates when education, assessment, and communication are emphasized. So systematic and integrative reviews show that education of frontline staff improves fall prevention outcomes. Structured communication enhances patient safety culture, and multifactorial approaches are more effective than single interventions. CNAs function as the eyes and the ears of the healthcare team, identifying early changes in mobility, behavior, and activities of daily living. and empowering CNAs with evidence-based leadership and patient safety principles should be of utmost importance. So that one of the quotes I put here is that nursing staff make a significant contribution to improving patient outcomes, and fall prevention programs led by nurses resulted in reductions in fall rates and fall-related complications. So for my PCOT question, I said, in post-acute and long-term care residents, how does implementation of a CNA-led fall risk communication and education program compared to current fall prevention practices affect fall rates and repeat falls over a 3-month period? This is a good PCOT question because we have that timing and the outline is measurable. So for my leadership and change frameworks, I use that focus guideline, and then I also use the Lewis change theory. So for that focus guideline, for FIND, I found that high fall rates and communication gaps in fall risk identification. So those big things that are leading to these falls. Organization is engaging CNAs, nurses, leadership, and therapy and support services to make sure that these falls reduce. Clarifying, I would clarify current fall prevention practices and reporting limitations. So what's causing the CNAs, or what guidelines are in place about falls already that is not being effective enough and not leading to a reduction in falls, but actually an increase. For understanding, evidence supports CNA involvement in structured communication. As we have seen by those other quotes, from the research, CNA involvement in that communication helps to prevent these falls. And then for selecting, I'm selecting a CNA-led education and standardized communication tools. So just making sure that CNAs are also grouped into there, and that those are like the main focus for getting this fall prevention program up and running. And then for the Lewis change theory, for that unfreeze phase, we would have to share fall data and emphasize that need for CNA engagement. So just being and addressing the problem and letting people know the reality of the situation. And then for a change, we would implement CNA education and communication tools. And then for a refreeze, we would integrate these processes into routine workflow and policy. So during that 3-month period, we'd be seeing if there was a reduction in fall rates. And then if there wasn't, we could make some modifications throughout that time period or change the plan altogether. So this is for my stakeholders and my roles. So our stakeholders would be the certified nursing assistants, who would be the main people, registered nurses, the nurse manager, physical therapy, the quality improvement team, facility leadership, families, housekeeping, and environmental services. So the CNAs, they would be those frontline observers. Those would be the main people communicating with the registered RNs. And those registered RNs, as we know, nurses are the main eyes and ears, and they're the ones who can actually do some medical implementation. So those RNs are going to assess those fall risk concerns and integrate those observations into their care planning and implement nursing interventions to prevent falls. For that nurse manager, which would be like the DON or the assistant director of nursing, they would just provide that leadership support, reinforce expectations, make sure that that staff understands what's going on and how to accurately document, and then ensure integration of the program into workflow. The PT, they're going to assess that mobility and balance, seeing like the score of the patient, like what devices they may need. The QI team, that would just be anybody who's going to help with the charting, and if we're going to do paper charting or if it's going to be online and on the computer, just making sure that that workflow is seamless. For facility leadership, they would help to allocate those resources, in that funding if needed, and just make sure that it supports that policy alignment. And then families, they're gonna let us know about their loved one, and help us to spread that education to that patient. Just, like telling them, call us from the call light instead of getting up for your own, and just helping with that care plan. And then the housekeeping and environmental services, they would just make sure that the environment is good, as to not let falls happen just because of clutter or something. So for my proposed changes, I would introduce a huddle prompt card to guide daily communication. So I know in hospitals, nurses will have like a little huddle, so just kind of bringing that in with the nurses and the CNAs for the night shift. And then also a checklist or a flag system to identify that mobility, behavior, and any changes. And that's, again, just like that charting. So CNAs can formally report during that huddle prompt, and then also during shift handoff, just to make sure that that fall risk is being communicated. And then nurses should incorporate observations into care planning and fall prevention statuses, by allowing those CNAs to receive targeted education on early fall risk indicators. So for my primary interventions, we would do CNA education sessions focused on early signs of increased fall risk, importance of timely and accurate reporting, the role of CNAs in patient care, making sure that that education is brief but effective, making sure that they know that they won't get reported, or it's going to be non-punitive if a fall does happen. We just want to know, and it's okay if they are assessing things wrong. It's just so that the nurses are initially just aware that a fall risk could happen. And then also that the education aligns with nursing practice. For our secondary interventions, we would do that CNA-led huddle prompts, and then we would have that charting, and then making sure that those CNAs are communicating to each other during shift reports, and then communicating to the nurse during those safety huddles, and then making sure that that nurse is following up and documenting any reported concerns. For tertiary, we would do some post-fall review that would include CNA input, like how can we make sure that this fall doesn't happen again, what caused this fall, things like that. And then we would also make sure that their care plan would address it, and then reinforce that communication process, just seeing how, like, if there was a fall prevented due to this CNA fall risk prevention program, that we would talk about it so that it would give the team members a reality check and see that it does work. And that also that continuous monitoring with residents with prior falls. So for that plan implementation, we would identify those workflow integration points, assign those leaderships, prepare education materials, and then for doing, we would obviously deliver that education, introduce the huddle, and then begin the reporting and charting. For checking, we would check those falls for the residents over a 3-month period, and check for compliance from the CNAs and the frequency of CNA reporting. And then for acting, we would review that fall data, modify education if needed, and strengthen sustainability. Some successes could be early identification of fall risk. Some challenges could be time constraints and workload. And for mitigation, it could be leadership reinforcement. So this project strengthens leadership skills and advocacy, collaboration, change management, and evidence-based decision-making, and it aligns with the organizational safety goals and professional nursing leadership standards. And these are my